Hey, I think we are on now. Welcome, everybody. I'm Jenny Shepard. I am here to help moderate this fabulous webinar today. So welcome, everyone, to today's PAHC Neonatal Hemodynamics Research Center's webinar. We have a very exciting topic today. It's called Controversies in Neonatal ECMO from a Hemodynamics Perspective. And actually, before I introduce our speaker today, I also want to acknowledge my co-moderator. Where are you? Mike Castaldo. There we go. Wave your hand. Thank you. And then I'll go ahead and introduce our speaker. We have Rachael Hyland today. She's a neonatologist with hemodynamic expertise and director of the NICU ECMO program at the University of Iowa Stead Family Children's Hospital. Her research interests include fetal to neonatal cardiovascular transition and the effects of intrauterine growth restriction on the developing heart. So thank you, Rachael, for coming today to give your talk. I also want to go ahead and introduce our panelists that will be coming on after the conclusion of the talk. We have three panelists today. First, we have Amir Ashrafi. He's a cardiac neonatologist and director of the Neonatal Cardiac Intensive Care Service Line at Chalk Children's Hospital, with an interest in caring for newborns with hemodynamic instability and congenital heart disease. He is also the medical director of the Neonatal ECMO program and associate medical director for the NICU. So thanks, Amir, for joining us. And then I have Maria Victoria Fraga, also known as Maky Fraga. She's a professor of pediatrics at the Perelman School of Medicine, University of Pennsylvania, and an attending neonatologist and member of the ECMO program at the Children's Hospital of Philadelphia. She serves as the director of neonatal point-of-care ultrasound and the newborn infant intensive care unit. And then last but not least, we have Patrick Sloan. He is the NICU Associate Medical Director and Medical Director of the Congenital Diaphragmatic Hernia team at St. Louis Children's Hospital. His academic interests are the care of infants with CDH, ECMO, and AKRT therapy in the NICU. So welcome, everybody. I'm looking forward to having a great talk and discussion afterward. And with that, I will give the floor to Rachael Hyland.
Thank you so much, Jenny. I appreciate it. And I'm very happy to be here. I told Faith and Patrick when they asked me about this topic, I'm incredibly interested, but feel somewhat underqualified. But again, really looking forward to the conversation and this discussion with our really expert panel at the end. As Jenny mentioned, I'm one of the hemodynamics faculty here and our NICU ECMO medical director for our program here at Iowa. For some context, we're a relatively smaller volume ECMO center. We have between 2 to 5 runs per year on average, but we're an extremely high volume hemodynamic center, as you guys know, with over 1,800 consults per year. And we use hemodynamics really routinely in the management of all our sick patients, including our ECMO babies. So I have no conflicts of interest to disclose, but I will say, this lecture was a little challenging to put together as we're going to discuss a topic that essentially is not well studied in a neonatal population and with really emerging data in our adults. I think that, many of us have been taught essentially that there really isn't a role for echocardiography during ECMO support, although we all probably would accept its benefit in the evaluation of patients pre-ECMO, particularly in this forum on an NHRC webinar, but then maybe even during weaning and clamp trials too. It's still probably all somewhat controversial. But I think the area of study that's emerging in hemodynamics and probably most interesting or at least controversial is the role of echo during ECLS runs and whether there's a role or potentially benefit of serial assessments even on full flow ECMO. So we'll spend our time today kind of reviewing what literature there is on echo and ECMO and then kind of extrapolate as we're able to some considerations for babies and neonates. And then finally, I'll share with you a little bit about how we're doing things at Iowa in our hemodynamic center, approaching T&E monitoring and kind of serial assessments on echo with a couple quick examples from patients that we've had here. So first, I thought we could just start with that elephant in the room. What many of us, myself included, are taught when learning about ECMO, that essentially echoes on full flow, particularly VA, are kind of useless or meaningless. So maybe let's just talk about why is that? Why are we taught that? And we'll get into this in more detail kind of through the talk. But as a reminder to get started for those of us that aren't doing a lot of ECMO, in VA ECMO, just remember we're giving, full heart-lung bypass support. And in neonates, with typical cannulation strategy, we have a drainage cannula sitting in the RA continually sucking out blood, so essentially removing all of our RV preload. And then our return cannula sits in the brachiocephalic aortic junction, providing forward flow down the descending, some degree retrograde, kind of depending on your positioning, but certainly causing relatively increased LV afterload. It's really not subtle at all on either side of the heart. In our VV patients, theoretically, we're kind of thinking this as a little bit more of a load neutral state because we're using in our neonates typically dual lumen cannulas that have drainage ports, SVC, IVC, but then reinjection of that oxygenated blood back into the RA. So ideally kind of net neutral, but that reinjection obviously is not load neutral, and interpreting like TR, atrial level shunting, those are all affected. So we'll talk about this more, but both of these states, VV and VA ECMO, are certainly altered hemodynamics. But in this talk, we're going to kind of reframe that. And instead of then using that to say, okay, echo is meaningless, instead, let's consider how and when echoes can be helpful. And even on full support, even on full VA, how potentially serial monitoring can still be useful when you have a strong understanding of what the pump is doing and what to expect and how that may offer some meaningful or actionable information to us. So the first question I wanted to address for the group and for the audience and myself was what guidance is there in the literature and are there guidelines around this? So looking first kind of with my hemodynamics hat as a hemodynamics person, I pulled up the 2024 updated ACE guidelines. And there is some endorsement here for TNE guidance, certainly pre-ECMO. It's actually specifically mentioned like in the pH management and risk stratification section. And then there's also kind of a recommendation, little inset box talking about either TNE or cardiac POCUS at cannulation and for serial assessments of ECMO cannula positioning. The ELSO guidelines coming from the ELSO world, so the ECMO side of the world, have a bit more varied information depending on the source that you use. In the neonatal guidelines, there's really only reference made for using echo for cannula positioning, and actually it's only in the VV section of the guideline when talking about positioning of the dual lumen cannulas. We'll talk about why that is a little bit more later. The general ELSO guidelines only have one little line talking about assessing function, but specifically once you're fully off support. But then there's also, if you look in like the supplemental section, there's a supplement on ultrasound use, which includes echo, and there's a VV and a VA ultrasound guideline section. And the VA section describes actually what it calls useful and safe practice, not necessarily a guideline, but safe or within reason, which includes echoes pre-ECMO to kind of see coexisting pathology, look at vessel size, rule out contraindication, then also for positioning and cannulation, and then during weaning and clamp trials. So in short, are there guidelines? I would say sort of in that, particularly for cannulation or cannula position, checking echoes pretty endorsed and deemed pretty safe practice. But outside of that, at least for neonates, we really don't have clear recommendations. There is, I would say, tacit approval, though, in the ELSO world to be using echo around ECMO, although it's most explicit, again, in our adults, not in our babies. So in absence then of clear guidelines, what's reasonable? This paper I really enjoyed. This is it's a comprehensive, a review and an opinion piece, essentially. It's from an adult cardiology and cardiac anesthesia group in Alabama, but it's a group that's really kind of at the forefront of echo plus ECMO in the US. And they essentially acknowledge what we just talked about, that echo assessments are being increasingly used around and during ECMO, but guidance is lacking. But they build a really nice framework for sort of phases of management that I think are pretty applicable and nicely translatable to kind of our neonatal setting as well. And we'll kind of use this framework as we kind of go through our talk today. So starting with the pre-echo assessment, I think this is the most probably straightforward and non-controversial section of our talk. So we're not really going to spend a whole lot of time on it because it could be its own comprehensive talk of how to respond and stabilize like your sick ECMO referrals. In this forum, I'm sure many of you already have built into your ECMO assessments for candidacy, for optimization, some form of cardiac echo-based assessment. But I do just want to emphasize that this is essentially absolutely within the wheelhouse of hemodynamics. It's essentially the design of a hemodynamics assessment for these patients. that are coming to your center or with you and worsening, comprehensive cardiovascular assessments can be a key, really important management steps to ideally avoid ECMO if you can. So we're optimizing our medical management of our lungs, our cardiovascular care. Again, this is just this hemodynamics. But listed below are some additional recommendations that you can see in the literature for evaluations recommended pre-ECMO. And some of these realistically can be accomplished by multiple services, whether it be radiology, cardiology, POCUS, hemodynamics, things like evaluating the vessel size, ruling out complications, ruling out existing thrombi, things like that, looking at your lines are all kind of within the pre-ECMO assessment wheelhouse. I think, though, that one argument you sometimes hear around these like very sick and unstable patients that are sort of peri and teetering pre-ECMO is a concern that the assessment itself, the echo itself, can make them worse, kind of like the stress of undergoing a scan. But that really hasn't been our experience here at least, and we've published data to support this. I've shown on the right here an example of an emergent scan protocol that we use. It's still comprehensive, but we use it in our crashing patient. And we've published and shown that we can do this really rapidly by a trained hemodynamic specialist. So this particular protocol in this paper was in a arguably quite challenging patient population to scan in a sick one in CDH patients. But we showed that we can do this comprehensive protocol in 7 minutes without any peri or post-scan clinical instability. In terms of like multiple markers being looked at, heart rate, blood pressures, FiO2, OI, respiratory scores. The middle is just one graph from that study, and that showed just an example in this case of heart rate trends. The baseline is in black, and then compared to during and post echo in the light gray. PCE stands for pediatric cardiology echo, and then T&E for a hemodynamics performed echo. And you can show, especially in like our focus scan, for instance, there really is no significant change in heart rate, and this is mirrored in the other examples I showed here on the left. So like I said, we're going to be brief in that section. This next session, though, on cannulation and initiation, this probably has the most published data in looking at using ultrasound or echo guidance for cannulation or for serial positioning assessment. It does certainly overlap kind of, I think, with the cardiac POCUS realm, isn't specific just to hemodynamics. And as more and more centers are becoming kind of facile with this, and I think as we're realizing the need, particularly in the VV kids, cannulas can be really finicky to place and align, and the role of echo and ultrasound, I think, is becoming increasingly recognized as maybe even necessary. And this is probably because the risk associated with cannula malpositioning is unfortunately really severe in our neonates, and the frequency is quite high, especially in babies. Not only can you easily have flow issues with malpositioning, but you're risking real injury and morbidity to the baby if those cannulas are malplaced. And that risk of structural injury is the really scary one. This table on the right is from a very experienced UK group led by Giles Peake, who's a pediatric surgeon. They included 72 neonatal respiratory ECMO patients. Here they were specifically looking retrospectively at their Avalon cannulas, which is a dual lumen VV cannula, and they actually had a close to 7% rate of cannula perforation requiring sternotomy in that cohort. They sort of published this as a cautionary when they were like switching from that cannula to going to a different cannula. But they did, in this group, they did use echo guidance at cannulation, but they don't comment on any rechecking of positioning over time. This figure on the left is a mixed both VV but also VA cohort with neonatal and pediatric patients. This is from the group in Indiana. And they looked at cohorts pre and post introduction of echo guidance at cannulation and then serially ongoing during ECMO support. And they essentially found hugely increased amounts of cannula malpositioning while they were looking for it, which isn't surprising, but certainly they were learning it was happening a lot more than they thought based on just looking at X-ray. And then I wanted to include this. This includes one of our wonderful panelists actually is on this study from CHOP. They looked at 37 patients on VV and VA ECMO where they utilized cardiac POCUS for serial assessment of the venous cannula. And they found a really high rate of malpositioning. In most cases, the cannulas were deep. And unfortunately, they showed a really poor concordance with X-ray imaging with only 57% agreement, which is not ideal. This is just a nice figure from their paper where you can see cannula position where it looks pretty reasonable on the X-ray panel in panel A. You see that little radial opaque dot kind of around the diaphragm where we'd expect it. But on the infant scan, you can clearly see on echo that the cannula is quite deep. And here I just wanted to include some images from ACE guidelines at the top and then this cardiothoracic anesthesia journal below, some optimal views of what you can get for particularly cannulas in the RA, which essentially are sort of bicable or somewhat kind of modified bicable subcostal views, which I wanted to share because I think the arterial cannulas tend to be a little bit more straightforward to assess and to see, but sometimes the venous cannulas can be more tricky to see. I wanted to highlight this other really recent paper that included multiple CHNC sites. This was 58 infants looking retrospectively, looking at their dual lumen BV cannulas. So again, here you'd be looking at that view I showed previously, looking at the dual lumen positioning within the RA. And I wanted to highlight from this paper, and this is a recent one from 2025, although still at cannulation, about 28% of centers were still using only X-ray right at cannulation. All of them now, so 100%, were using at least additionally echo guidance or ultrasound guidance for confirmation of cannula positioning post-placement. And they provide a summary recommendation, which includes frequent looking. So frequent focus assessments with a low threshold for a full echo for any infants using this type of dual lumen cannula. So again, highlighting how important this is to our providers as people are getting more facile with ultrasound, using it more and more frequently. And now, in this paper, at least with the CHNC recommending ultrasound or echo guidance. In real life, as I alluded to, though, things aren't always as crisp and easy as they are when you look in a journal article. So I just wanted to caution that it does take time to perfect this skill. So when we're talking about whoever's performing the echo, be it HD or be it POCUS or cardiology, just be mindful that experience, really does impact your ability to provide a good assessment and interpretation. Here are some clips as an example, and I use this one because I think this is an example where you could get maybe a little bit confused. There's, extra tissue in the RA. You get that right atrial appendage below. You want to make sure that you're really clearly showing the venous cannula tip and not something else to your providers when you're looking at these assessments. We repositioned this cannula sterilely, and here's a nice picture at the end. And again, this is pretty clear, but it's not always that easily. You can be fooled by other structures. So I think having some facility and ability to kind of smoothly go between different views in echo, like checking certainly your subcostal, your modified bicable, but then being able to smoothly move into, a four chamber coming from above or doing a modified short axis. Being able to move around is really important and have a really good 3D understanding of the cardiovascular anatomy, particularly when we're imaging challenging patients, like, you think are imbalance or a baby's in a silo, or, you're sterile and they've got this much open to you, the lungs are down and it's hard to see. It takes time to get comfortable and good at the skill. So continuing on in our framework, this next section is the one that I'm really interested in. This is what we're going to spend the most of our talk on, this in the last portion, echo assessment on ECMO. And the framework we have from that first paper kind of focused more on troubleshooting and emergencies, but a few centers, including our own and some others that I'm going to reference, are using assessments on ECMO serially as well. So we'll talk about that here. And this is the controversial part. So first, I want to highlight areas where echo can essentially be added to your skills, your armamentarium, your toolbox when there are issues on ECMO. Not at all to say it should take the place of your usual clinical response. When you get your low flow alarm, please don't wait for the echo machine, respond as you would, try your fluid, your RPMs, whatever you need to do, but add in echo assessments and you might find it will help you, particularly looking for things like, is there a new thrombus? Is there an effusion causing compression? If your cannula's moved, what's the volume status? Those are all questions that can be easily and accurately answered by echo. I think this change in arterial line pulsatility should be something that is just telling you that something's changed for better or for worse, depending on which way we're going. But new loss of pulsatility should be somewhat concerning to you, particularly, looking at your LV functional status, LV afterload, most importantly, which you can take a look at pretty accurately and quickly with echo, and we'll show that in later clips. We talked about how X-ray and echo, unfortunately, don't have great concordance. But certainly if you find that lines look odd or malplaced on your X-ray, probably likely that, there's something going on in echo as well, but that's the time to look. And then this last one probably isn't an emergency, but if you notice big changes, improvements, particularly like in your SpO2, your lactates, this may be your time to sort of add in those functional assessments if you aren't already doing that routinely, essentially to help support like your weaning and coming down quickly when you and if you see recovery, to kind of help support that process. And then for serial monitoring assessments in ECMO, there are a smaller number of centers routinely doing this, but I'll share with you what data are available in those that are. And monitoring that really has high impact. We talked already about cannula positioning serially. Also looking and assessing serially for clot development is important. And then this is the area I'm interested in, watching serial changes in ventricular size and function and shunt directional changes. And finally, in an area with a little bit more data, particularly in our adults, but looking at LV size and the AV valve serially, and we'll talk about why that is. And then I'll pause and just remind us here and go into a little bit more detail, as we briefly mentioned before. But again, here, there are certainly altered loading conditions, especially on full VA ECMO support. But as opposed to, again, saying throughout the echo, as hemodynamic specialists, we just have to be thoughtful and mindful of them as we offer our interpretation and assessment of our echo findings. So these two principles, specifically the stress velocity relationship for the LV and Frank Sterling for the RV, these are absolutely going to be at play. So when we comment, for example, on, there's mild to moderate RV dysfunction, we put that in our echo report, we should essentially also be telling our clinicians that we're expecting that finding. It's secondary to loss of preload, and there's an expected decrease in stroke volume, and that's okay. Similarly, like on the left, I can tell my clinician colleagues, yes, LV cardiac output is down, but there's increased afterload, and my stress velocity relationship explains that decreased volume. But let's watch it over time. Let's be mindful of our blood pressures and our flows. Let's make sure our AV valve is still opening, et cetera. So, using these principles, being mindful of them, being understanding what the patient and the pump are doing, need to be part of your interpretation when you're offering or using an echo on full flow support. And that's essentially the role of this group with representation. This is from a group in the UK and in Spain, describing how they approach routine echo assessments on echo in neonatal and pediatric patients. And they do the same thing that I've been doing with this talk, acknowledging that there's limited data to support, but they describe their approach. And what I've shown here on the right is their protocol, and they're essentially performing what we would do with a full hemodynamic echo and using those data serially over time to guide medication and flow titration to help prompt weaning. But they freely admit, how frequently to routinely check, unknown, and there aren't yet outcome data to suggest that this approach does something specifically like improving the length of course or morbidity and mortality, maybe yet. There are very few studies that actually show functional metrics and values in ECMO support. Here's one, though, I was able to find in an adult population that was really interesting. It could maybe represent a model of what we could consider for future neonatal studies. This was from a cardiac anesthesia and cardiac surgery group at Tufts and Harvard Medical Centers in Boston. It was a retrospective study comparing RV and LV functional metrics, essentially using a graded score of 1 to 5, with a higher score being better. For the LV, it was more quantitative. It was based off of EF. The RV was subjective, unfortunately, but they did compare time points pre-cannulation, during, like kind of the middle. They picked the study closest to the middle of the run, and then post-support. And what I think is really interesting from the study is what I highlighted in the boxes is that while there wasn't a significant difference in the baseline sort of during echo function scores for survivors to non-survivors, there was a significant difference in the during to post, that comparison. Likely, honestly, this was probably just driven mostly by the post score, but it still, I think, suggests that at least having that baseline data during the run and perhaps at multiple epochs could be useful and could be thought about for sort of risk stratifications for these patients. One area that's probably the most emerging recognition and support for echo monitoring during ECMO is to mitigate LV overload. And in our neonatal population, generally, we're less prone to this problem, to severe LV distension compared to our adults, as most of our patients are still going to have, patent nature level shunts. with the PFO essentially serving as our sort of pop-off for the LV pressure. But in older infants without an atrial communication or if flow is restricted, this risk really does develop. And unfortunately, there are a lot of consequences. In the adult literature specifically, there's really clear correlation between length of ECMO run, morbidity, and mortality once you get into LV overload states. And this pressure volume loop I included in the middle kind of demonstrates the theory behind that, essentially showing that as ECMO flow increases, there's serially increasing afterload against the LV. So increasing end-diastolic pressure, end-diastolic volume, which is nonlinear, but once it starts to wrap up, we start to really rapidly increase. And as that happens, obviously because of that pressure differential, the aortic valve is less able to open and for shorter durations, which then shortens the stroke volume, the LV progressively descends, things get worse and worse, and that consequence can be pretty significant. Related to a couple of things, obviously myocardial wall stress, but back up to pulmonary venous hypertension, which has obvious negative consequences in terms of pulmonary edema. And then eventually enough pressure differential, if the AV valve really isn't opening, that can be devastating. We can form intracardiac thrombi, not a good thing to happen. We don't need to go into this detail, but I included just a table as an example. Interventions, first line things before we get to kind of surgical interventions are going to be things like weaning flow, vasodilators, diuretics, but there's a whole host of interventional approaches in the adult world. In our neonatal world tends to be, if needed, first line like a atrial septostomy, which I mentioned here. But something, that we should be mindful of. And what's important, and I think in this particular category, though, in terms of echo, is that it's one of the more clear examples where there's recognition from ECMO governing bodies of the role of echocardiography during ECMO runs, even in neonates. And I say that because this is a paper, this is from a Delphi group consortium, including representation from multiple societies, ELSO, and really big names in the neonatal and pediatric ECMO field. The first authors, Peta, Alexander, the seniors, Ryan Barbaro, we know those names, but together consensus on how to define and report various adverse outcomes on ECMO. And in the LV overload definition, and one of many, but the LV overload definition in this paper, they specifically name as part of the definition various echo-specific markers, which I think I'm taking it in a sense as endorsing echo use on ECMO from ELSO, and recognizing though that perhaps serial assessments could be useful and that they consider markers like dilation, which we see over time, and EF assessments, which also you can grade over time before getting to the cutoffs needed for this definition. Finally, I wanted to talk about the role of echo during weaning from support. And I think many of us are probably, especially again in this forum, used to seeking maybe some echo guidance at this phase, certainly more so than we're used to during support. So I'd call this sort of a plus-minus controversial section of the talk. During VA ECMO weaning, particularly in neonates, though, I think just keep in mind when we're doing our assessments that even what we're calling low flow, depending on the size of your patient, could still be significant support. Like in our center, for instance, we don't flow below 200 mils flat, which, you've got a little 3-kilo baby that's still over 60 per kilo. That's not insignificant. The mechanism of weaning, though, really does matter. Your best and most accurate assessment of true patient condition is during a full clamp trial. But as we've been emphasizing through this talk, serial assessments and change certainly still gives insight into changing cardiovascular mechanics. And I'll show in a case example at the end, but what we're really looking for and looking at is progression in our VTIs and our cardiac output. And critically, we're looking at that RV as we start to have increased preload as flows come down, as we're sucking less and less, we expect to see serial recovery in those functional markers. And, likely less critical, but I think there's probably still a role in VV ECMO as well. Although, again, there shouldn't be drastic cardiovascular changes. Certainly, if there's inadequate lung recovery while you're weaning support, those changes in oxygenation and pH are certainly going to cause cardiac functional changes, particularly for our RV, again, our vulnerable ventricle. So looking to make sure you're really maintaining those functional markers can be really useful. And I just put this in as a sidebar. Some centers are now also looking at new kind of novel weaning strategies like pump-controlled retrograde trials off, where the circuit runs backwards, where native heart function is supplying full support, but there's also a much larger extra volume of distribution, which likely impacts our hemodynamics that there's nothing published on yet. So if anyone is doing this, please, at some point reach out to me if you would. I'm really curious and I would love to hear your experience with that. The data in this section are limited. I know I keep saying that, but here is one study I thought was really cool. This is from a group in South Korea, published from several years ago now, actually, so I'm looking forward to seeing what's next on their list. But this was a multi-center registry, again in South Korea, with 92 adult patients on VA ECMO, where they performed a full TTE on both full support and then during a low flow trial, and then they assessed markers that predicted successful weaning fully off of support. And they found several metrics that were associated or trended with success in weaning off, but the two that were most sensitive and specific to successful weaning were tissue Doppler measurements. And I'll show that in this slide. They comment that perhaps TDI parameters are less sensitive to low variation. And that's something that we see and we talk about in the HD world too, although I know there's some mixed opinions. But that may explain this finding, and I think that's a really cool potential area of study. The two associations that they showed were any change in the LV lateral wall E prime, that's shown on the figure on the left, and then a 10% or greater improvement in the RV lateral wall S prime. And these measurements, these are relatively, honestly, straightforward to obtain and measure. And I feel like when we're teaching our trainees, for instance, even more accurate to reproducibly get than an LVEF even. So I think this is the type of work that's really hugely needed, and there's nothing like it in the neo literature yet. Hopefully more to come on that topic. And finally, I'll just show you briefly how our program is approaching these patients and some case examples. So again, we're at Iowa. We're a very comprehensive hemodynamics program, so we're definitely biased always towards more and lots of echoes. We see patients at each of the time points we talked about. So we do comprehensive early assessments on all of our sick babies, all of our peri-ECMO assessments. At times, they're limited scans in a crashing patient, but then we always tie them to a complete scan. We're doing everything we can, honestly, to avoid ECMO if we're able to. We also here provide sterile guidance at the time of cannulation. So we'll gown up and check cannulas before the x-ray and before the surgeon's brake scrub. And depending on the surgeon, we'll do the echo, and then they might just come down and wait for x-ray later, but they won't stay sterile if they're happy with how things look on our echo. And then on support, this is how we're different from probably a lot of places, in that we're seeing the babies really frequently. Usually daily to start, and then we space to kind of 2 to 3 times weekly, depending on their trajectory. And then finally, we're really intimately and closely involved in all of our weaning to low flow and clamp trials. We do a full baseline echo on full support, and then we typically will rescan halfway to low flow, on low flow, and then on a full clamp trial. And these are limited, but include still the basics that you'll see within the content here. And I wanted to close with kind of 2 quick case examples to show what this looks like in practice. The case details don't matter so much. This is an outborn baby transferred with super sick meconium, HIE, hypoxic respiratory failure, ultimately was cannulated onto VA ECMO for worsening pH, RV function, systemic hypotension, escalating support, kind of all the things. But what I want to highlight from this case is the ductal management, which I think is something that can get us into trouble in ECMO, and something I think that's kind of unique to our neonatal population that I think serial echo assessments can be really useful for. So this baby, like many I think that we manage in our NICUs, with severe early resistance-mediated pulmonary hypertension with RV dilation and dysfunction. We had them on PGE at the time of cannulation for ductal patency, and they had a mostly right to left kind of giant PDA. But, even by ECMO day 2, they actually already had some transition to more left to right flow through the ductal shunt, which I've shown here in that Doppler. And then on day 5, see if that'll play, yes, we actually see this giant left to right pulsatile shunt. So although, again, this baby went on super sick with super systemic pH, the physiology is clearly changing and has changed. And I think sometimes, in neonatology, we can have a bit of a, appropriate, we want to do the best for the babies. We have a little bit of a fear response around that duct, wanting to make sure it's there if we need it down the line. But, what we felt and what you can clearly see, what you start to see when you start looking at a lot of echoes and at outputs, is that you really can get into trouble with pulmonary overcirculation, which is not helpful for your pulmonary vascular bed, pulmonary edema. You can get secondary kind of flow-driven pH too. So when you start seeing this and how we approach this, in this case, with this echo, the RV had recovered. It actually had pretty robust function, even on full support. We felt comfortable stopping the PGE, allowing the duct to close while we continue to monitor very closely. And here's, again, a real example. This patient had a 10-day run. We had a lot of echoes during that run, which is probably, I think, 8 echoes during their 10 days. But she did really well. Her duct closed and she came off support on day 10 without issue. And then really just briefly, I wanted to show kind of our expected trajectory when we're doing our assessments on our low flow and clamp trials. So here's an example, if this will play, on the start of a trial on full flow with a couple clips, just showing at the beginning mild to moderate RV systolic dysfunction at the start of our scan, which again, we would have commented in this report, not unexpected on full VO ECMO flow, totally fine to proceed and keep going. As we moved the patient kind of serially into lower flows, we saw what we hoped to, and that we had serial improvement in a lot of markers for the RV. So the TAPC, the RV output, their RVS prime, so that's a tissue Doppler measurement, for instance. And then finally, as we got to here, during their clamp trial, they actually had low normal RV systolic function, normal RV cardiac output, and only mild pH. So we felt very comfortable based on this proceeding with decannulation, and the patient did do well. So through this talk, we've covered a lot of ground. We've essentially told you there are no guidelines for what we're doing, but there are some existing frameworks that I think are worth considering, and some limited data to support at the least continuing to gather further data to support what we do and to inform patient care. And I really wanted this talk to be as data-driven as possible. It was a little bit of a struggle, as this really is a burgeoning field, but I think it's only going to continue given the complexity and challenges of our patient population that seems like over time is only increasing. If we look at the types of patients we're putting on ECMO now, it's like the sickest of the sick, the most complex CDH patients, the babies with giant villocele, renal anomalies. The field is getting more complex. And I think adding in additional physiologic information, I hope, can only help us. Of course, that's with the caveat that echoes on their own aren't the answer. It's the interpretation and understanding along with the clinical context. I think that's where we're going to have the most utility and help from this. So if I had, clinical takeaways for you, I would say, I really do think about each of the steps in this framework, and maybe think about in your center, if you're not doing any of these, where you might think about adding into your care if you're not doing so already. I'll stress again that both hemodynamics and ECMO are certainly team sports. They require continuous engagement and learning, and to interpret these echoes with fidelity. You need experience and knowledge personally, but also just a really open mindset, and to understand that it's changed over time. Again, that's really what's helping us. And finally, I think collaboration with our partners in the echo world is going to include our cardiac focus providers, our cardiologists, and that will really continue to be needed as we kind of go forward and build more data for these patients. A lot of citations here, and happy to kind of looking forward to the discussion. Thank you so much.
Rachael, thank you so much. That was awesome. Honestly, it was a fantastic presentation. A lot of questions bubbling up. I see Jenny has joined us. I'm going to ask Dr. Sloan, Dr. Fraga, and Dr. Ashrafi to turn on their cameras, because we are going to start with the questions. One thing I'm going to say to the entire audience, though, is we want to hear from you as well. And so please, in the webinar chat, throw some questions our way so we can have our experts chime in. And so as we are waiting for the audience to build up that courage to ask some questions, I've got one. And it really honestly goes right back to who should be doing these echoes. You mentioned that ACE and ELSO are advocating for cardiac POCUS and T&E to be able to help confirm things such as the ECMO cannula positioning, taking a look at some of the adverse effects from a pericardial effusion and tamponade physiology. But I really want to ask this question to the panel, and I'm going to actually maybe pick on Dr. Fraga first to get the conversation going. And Maky, how are you?
Sounds good.
I'm going to say, could broader adoption of a neonatologist perform echo or ultrasound improve timeliness and create a more holistic approach of decision-making during ECMO? And with that, what risks may accompany with that shift in responsibility?
Yeah, okay, that's a great question. So your first question was who should be doing this, right? Yeah. So I think we have different applications, right, for different things. So as you know, I am a 100% advocate for point-of-care ultrasound, and I think it has a very important role during ECMO in determining cannula position during cannulation. Like my team has been trained, and we are doing that in our NICU at CHOP by using point-of-care ultrasound. Also, very useful to detect complications. As you said, your cannula perforated the right atrium, and you ended up with a pericardial effusion. Very quickly, you can assess that by point-of-care ultrasound, or assessing pleural effusions, right? When you are trying to get the child off and you want to see, should we put a chest tube or not? What's happening? Is this all atelectasis? Is this just an asarca? Is it pleural effusion? So I think that in that field, point-of-care ultrasound has a huge role. But I think that if we are using echo, right, to assess successful, like weaning off, VA, or we are assessing, function while on VV, ECMO, and pulmonary pressures, I think that requires a much more comprehensive training, and I think that that's definitely more the field for T&E or cardiology.
Keith, that's really helpful to hear. I'm going to switch the pendulum a little bit to Dr. Sloan. And Dr. Sloan, I know you've kind of informed us that currently at your center, you don't have neonatologist-driven echocardiography. I'm not sure how much a point-of-care ultrasound is at play, but let's look at that end of the spectrum where it's being driven by cardiologists and how that interaction, that dynamic that Rachael said is so important. How that is at your center, and is there opportunity to evolve where the neonatologists have the probe in hand?
Yeah, thank you. At our center, we have cardiology come at the time of cannulation, especially if it's a VV cannulation, to put the probe on and read the echo in real time for us so that we know that the cannula is in good position and that we don't have any of these sort of very high-risk side effects like perforation or pericardial effusion. And for that to work, you have to have a really good collaboration with your cardiology program. And that took some time. I think there was some time where the role of echo was questioned. You just get an x-ray, that's enough. You're flowing, that's totally fine. And I think one of the papers that Rachael showed that we've also found is that when we look, we find the cannula is often not exactly where we think it is. It may not be in a good spot. So for us, we use cardiology. We had to build that relationship, and we'll have an attending come to the bedside to read for us during cannulation, or they'll be on video. Like if it's 2:00 in the morning, we may not have an attending in house. So they'll be on video with the fellow doing the echo. The role for the neonatologist is clear if they're trained. They have to have competency in echo for this to be safe. But we bring everything else to the patient. We know the ECMO physiology. We know the physiology of the patient. We know the complications that we're looking for. So there definitely is a role for having the neonatologist do it. And I think that moving forward, as more people are trained, that really would fall into our purview, just because we have as you mentioned the word holistic view of the entire patient. And so we have POCUS, we have point-of-care ultrasound for lines, line monitoring, placement of arterial lines, that sort of thing. But we haven't moved fully to cannula positioning. We use cardiology for that.
Yeah, can I just add something? Yeah, I just want to say that, I've been doing this for the last 12 years, and I'd always scan our patients on ECMO. We have about 25 ECMO a year. And I have learned so much as a neonatologist about this, right? So before, we used to have echo techs that would come and look at cannulas. But, we realized that they really didn't know exactly how the cannula looked like and, and how to position them. So for example, if we place a BB cannula, we use crescent cannulas. There are 13 French, right? And like a term baby right atrium is like what, 2 centimeter average? So from the tip of that cannula to the reinfusion port, there is 1.3 centimeters. So you know that you have just so small, place just to play with. So, and we also have seen that when we are cannulated, I'm doing the ultrasound and the cannula looks great, but there is a shoulder roll. And that changes completely the picture, right? So before I tell the surgeon, this is great, remove the shoulder roll because the cannula position changes completely and the angle changes completely. So there are all these many things that I've learned over time that I think, they're so important for us to know and make the cannulation so much safer. And then also we've seen that within the first 48 hours, the cannulas move all the time because there is fluid shift, there is anasarca developing, atelectasis, everything changes. So we do have a protocol. We had to develop a protocol where we actually surveillance these cannulas every day for the first 72 hours, actually.
Maky, and Dr. Sloan, you mentioned this as well, and Rachael also talked about it. And Amir, I just wanted to get your opinion on this. We're hearing a lot comes from experience. A lot comes from being able to do this. And talking to my colleagues here in Vancouver about who's in charge, it's got to be a very experienced sonographer, if you will. And so in your center, Amir, how do you ensure that experience is there? How do you develop those competencies, the format of the quality assurance when expanding into a neonatologist perform echo or ultrasound practice within the ECMO domain? How is that done?
Good question. First of all, thanks for the opportunity, Rachael. Phenomenal talk, and it's great to share the stage with all of you. You're exactly right. Competency does matter. I want to echo a lot of the things that Maky said. Pretty much if Maky speaks, then I'm always listening. And if there's anything that Maky says that I don't disagree with, I go, what does she know that I don't know? I agree with everything you've said. The nuance is important. Experience is important. To answer your question, really, Michael, there's no magic to it other than do it again, and then do it again, and then do it again. I'm happy to say that at our center, we've developed a tremendous amount of confidence between us, our cardiologists, and our surgeons. Many of the times, historically, cardiology would always check cannula position. Now, many times they don't check until the next day. If one of the hemodynamics attendings is on, we do the echo and we confirm position. We are probably 2 standard deviations away from normal in that we do have our own T&E program, and we do realize, Michael, to your point, experience matters, nuance matters, and this is a game of millimeters and not just, so experience matters, positioning matters. We get an echo every single day, sometimes twice a day on these babies, not necessarily to look at RV function or LV function, but really to look at the nuances, look at flow, look at cannula positions, look at ductal shunts. So we get echoes every day, and that's how we contribute, I guess, or that's how we back up our competencies.
Rach, I know we had a short discussion about this in the days leading up to this. Can you share the Iowa experience? Because I thought that was really enlightening as well.
Yeah, regarding cannula positioning or frequency. So like everyone else is saying, we do use, we have hemodynamic specialists that do all of our cannula positioning in the moment in real time. So we're sterile and gowned up and ready to scan. So we provide that service in real time. And then similar to, I think, everyone else, we're checking serially afterwards and looking at movement. I will say, this isn't just like your cardiologist or POCUS person or HD person who's checking, but it's also your partnership with your surgeons, because we found that has evolved over time as well, because we've had varying interest in like providing that service of repositioning acutely and quickly. So many times, as we were starting to build that, comfort with our surgeons and being able to be immediately available or willing to reposition cannulas, we're doing a lot of things where like we have the specialists with us at bedside and we're like moving the patient, we're putting in a shoulder roll, they're doing this or that, and adjusting with them as we need to. So that's part of it too. But now, with time, just like everyone's kind of been echoing, like with their cardiologist, in our case, us with our surgeons, we've kind of built a relationship where they kind of trust and work with us to move those cannulas when we really feel like it's needed. And they're willing to do that with us. When we do reposition, we're right there sterile also, though, and helping to look.
One thing I will say, if I can just jump in here, Michael, I feel like the conversation is leaning towards the venous side of things, but the arterial cannula is also equally important. And that's even, I don't want to say more difficult, but it's a different kind of difficult.
Yeah.
So make sure that it's not too deep.
Yeah. Especially when we, like what I was talking about, like pointing towards the LV, we get into a lot of trouble. So that is a definitely dangerous situation to be in, particularly if you're getting close to the valve. You can cause a lot of injury and trauma, which you really, really can't have.
Yeah, I was just gonna apologize.
Yeah, please.
Just gonna jump in around the arterial cannula. We have found that can be a big challenge, especially CDH is my sort of interest. But if we repair on ECMO, and then we have this mediastinal shift, that sort of repair and post repair really, really strongly would recommend echo of the cannula position, because if it changes, it can, one, you can cut out flows on the venous side, and two, that arterial cannula sometimes we see will displace downward, and then you may lose pulsatility, or you have trouble opening the aortic valve, and that is not good for CDH who may already have some LV dysfunction.
Absolutely. I'm going to take a moment right now. Jenny, I just want to make sure I'm not missing anything from the audience or yourself. Is there any questions that have started to pop up from audience?
I haven't seen anything in the chat, but I do have a question of my own, if that's okay. And this is kind of open to our speaker and all the panelists. I was just wondering about, I'm hearing about a lot of collaboration and who all is involved when you have echo and ECMO. I'm just curious, is it the same groups of people, the neonatologists taking care of the kids, like the same ones who do mostly your hemodynamics consults and taking care of your cardiac population who also do ECMO, or how do you guys sort of separate those out, or is it all the same people?
I'm happy to start, and then I'm curious what everyone else has to say, because my experience has been it's a little bit different at each institution. And that's something that is just interesting to me as a junior faculty, learning about ECMO at different institutions and trying to take things from different places. Everywhere feels a little bit siloed in the way they bring up their programs and the specific way that they approach things. They approach patient care, particularly in these nuanced fields of ECMO, which is just interesting and super fun as a junior person learning. But in our case, we have actually multiple camps that are all caring for these patients. We have a neonatologist primary person, but then we have separately ECMO consulting neonatologists, so a small group of core neonatologists who have additional ECMO expertise. Then we have a separate camp of our hemodynamic specialists who are also consulting on those patients. We have surgeons who are also, involved, but not primary, and kind of consulting and working with us. So we've got multiple camps of people in our center because, again, our hemodynamics program is so strong and kind of owns a lot of the cardiovascular care in the NICU. Our cardiologists aren't typically involved unless there's congenital heart disease. So even in our CDHs, it's going to be a hemodynamic specialist providing that cardiac piece. But there are certainly a lot of players, and that collaboration piece, whoever your players are, kind of as I mentioned, is really key. So curious how other people approach it, but that's what we do here.
Yeah, at my institution, I agree. Every institution is different. At my institution, we have a very small team that does ECMO. We are only 6 attendants that take care of the ECMO babies, and most of them are CDHs, as you know. And so we work along very close with the surgeons. So these ECMO attendants, some of them are trained in ultrasound, some others are not. So, for cannulation, cannula position, and other things, we have a point-of-care ultrasound team that is available all the time to look at these cannulas. And then we have also a small group of cardiologists that are the pulmonary hypertension cardiologists. It's also very small that come to the NICU and take care of these babies. So we do work with them very closely. And as far as, hemodynamics, we have few people now already trained by our cardiologists and that has gone elsewhere that are allowed, or, they can perform TNE.
Just want to take a quick reflection. Laura, I'm not sure, but I think we're getting a little bit of feedback from people saying the chat is not, it's disabled. Just wonder if we can just take a look at that, just in case there is a bit of a glitch, and that's why we're not getting any audience participation.
So the
Sorry,
chat is enabled only for the panelists, but the Q&A should be open. So that would be the preferred way, if that's okay for attendees to put in some questions. I can open up the chat in the meantime, but.
Yeah, that might be helpful just to make sure, just so that we're not missing any of the questions. Sorry, Dr. Sloan, if you wanted to just finish your thought.
Oh yeah, no worries. I was just gonna, so our model at Washington University is we have a core ECMO team. There's 6 faculty right now, and we cohort congenital diaphragmatic hernia, severe pulmonary hypertension, giant phalloceal, and ECMO and AKRT all on the same team. So it's the same group of neonatologists caring for all of these kids. And when we have cardiology as our partner for imaging, I would just put in a plug that, Rachael mentioned this during her talk, that we're doing less neonatal respiratory ECMO across the country, across centers, and the complexity of kids is increasing. So, there's this large category of other that includes patients with KKIT, giant phalloceal. The diaphragms are incredibly severe going on. And so having a core team, I think a lot of centers have moved to some sort of core ECMO focused team, because low frequency events like ECMO require high expertise, and the experience really makes a difference in delivering better care. So that's the model that we have at St. Louis Children's.
We're no different at CHOC. Our neonatal cardiac team takes care of all the ECMO patients, and we're the ones that do all of our T&Es as well.
I'm seeing Laura's got the chat open. Kindly place your questions. Perfect. Excellent. Thank you so much. Okay, so I'm going to actually pivot towards the limited amount of data that's out there, and I think Rachael was able to communicate that. So we know that if anybody can comment on normative hemodynamic data for patients on ECMO, that'd be fantastic. And I do want to bring up an example that was highlighted by Rachael, and that is that on VA ECMO, you're fundamentally altering loading conditions, and so making really your echo indices difficult to interpret. So what's out there, what's normative, what can we use? And when you're on full flow, what echo parameters do you trust when assessing a ventricular recovery? Because Rachael really pointed that out. It's the literature is not there yet. So I might pick on Dr. Sloan. Why don't you take us off first?
So you're pushing me a little bit outside of my experience window and knowledge here, since I'm not trained in the reading of echocardiography. But the normative data sort of flows through our cardiology team. What I will say is that if we step back from like a bigger perspective of the role of echo during the ECMO run, right? You put these kids on ECMO to restore DO2 to VO2, right? And ECMO is not treating anything that it's not treating congenital diaphragmatic hernia, it's not treating pulmonary hypertension. And so that same pathophysiology is occurring while you've just restored oxygen consumption, and echo can help guide recovery, I think. And so we don't do daily echo, but we have switched to much more frequent echocardiographic monitoring during the run, because if a patient persists with severe LV dysfunction, they're definitely not ready to come off. And while you have other markers like pulsatility and NEARS and other things, there is a role, I think, for echo in determining how the patient is progressing, especially in longer, more complicated runs. Speaking to normative data, I'm gonna defer that to the other experts on the panel.
I can try to tackle that one, Michael. Good question. Rachael said something earlier in her talk that I think is really the most important, is that echo doesn't replace your clinical assessment, especially when it comes to ECMO. I mean, all things T&E shouldn't replace your clinical assessment, but especially in ECMO. There is so much objective data when you walk into the room for the kid who's not well. What is the venous pressure? What is the arterial pressure? What is the pulsatility? That alone gives you a tremendous amount of hemodynamic data of what's happening. So when you ask, what does T&E add to this? Normative data, I think, is tricky, and I think we can pretty comfortably say there's not much in terms of normative data. It's really going to be one of two things in our world. Is cannula position, check, we've discussed. Number two is the majority of our kids go on for severe pH. So looking at ductal shunting, there's always a controversy. Should you put nitric on when the kid's on ECMO, or when you come off ECMO, should nitric come off as well? And so just trying to manage that PVR to SVR relationship becomes key. We do manage some of our cardiac ECMOs as our cardiac neonatologists. We recently had a couple of babies with severe cardiomyopathy that cannulated to VA ECMO, so following heart function is critical. But more than anything, it's really a trend of how things are going. I hate to say this, but it's true. Practice for our fellows. Put in a plug there. We, if you're interested in hemodynamic fellowship, reach out. And that's really, I think, the bulk of it. But I don't think there's any normative data. But I'm open to somebody pushing back on that and saying, no, that's not necessarily the right way to do it.
No, I agree. I don't think there is any normative data. But I was going to add, Amir, I agree with you. Like even at the beginning of a VA ECMO run, when you're on full flow, there is always some native RV, LV output, right? That, for us to look with echo, as you said, the PDA, how is it shunting, the size, we're very pro prostaglandins, super pro, and we are always looking at the PDA and see if it is becoming restrictive or not. Even on full VA ECMO flow, right? You can get a lot of information. And as you said, like putting all together with the clinical picture, the pulsatility, and everything that you just said.
Yeah, I agree. I kind of try to emphasize this in the talk. It's the serial assessment that helps. I will say though that there are probably some outward bounds that give me pause or make me worried when I'm looking at an ECMO via ECMO assessment. So I think, are there going to be normative values that are translatable across all disease states? No. But could we, and is it on my list to show what kind of bounds we are seeing routinely, particularly towards recovery, and maybe, again, kind of like the papers I was showing about during weaning and clamp trials, some maybe expectations on what you can see dynamically as you come down on flow, I think could be translatable and useful in our neonates, and showing, recovery of metrics to what percentage they're recovering, that kind of stuff. I think we could relate to maybe a functional outcome. So that's kind of where I'm interested in the question of normative data and those percentage changes and what that means for weaning and clamping. So something I'm interested in. If other people are doing it, collaborate with me. Sounds be great.
Totally. Can I modify my answer, Michael, on that last one? It depends if we're VV or VA. I think for VV, assessing LV function is critically important. For VA, if not. So I just want to put that one caveat. But I guess, and then the other part that Rachael kind of expanded my mind on, thank you, weaning becomes, I think, very helpful in assessing RV function, LV function. Is this baby ready to come off or not? And so your pre-ECMO evaluation becomes almost identical to your pre-decannulation evaluation, and making sure that whatever physiology you were worried about has since improved. So I think those are the two real keys in which it can be helpful and change your management.
Yeah, and I also agree, as you said, Rachael, that, even low flow is a lot of support, right? Like it is still, the patient is still in a lot of support. So I think that we have to assess, before the cannulation, weaning off, perform clamp trials, right? I think this is the only way, but I always have this question, right? How to predict successful decannulation just by looking at your clamp trial. Of course, you look at everything, right? FiO2, your gas, your CO2, your PO2, so many other parameters, blood pressure, everything. But when we look at echo parameters, right, we're clamping for 10 minutes, because then we have to flash the cannulas, and we can, go longer than that. And maybe in those 10 minutes, the patient looks okay-ish, right? But is this sustainable? And then over time, what's going to happen to this patient in 6 hours? So, that's always my question. How can, although we almost always successfully decannulate, but how to be able to truly predict, by using by using echo mainly.
So, Maky, with that, this lack of standardized weaning protocols, should the field prioritize development of a consensus-based weaning protocol now, Or do we need to wait for stronger evidence before standardization? Like this is, I'm hearing some agreement, but is in the centers that are currently performing, the 4 of you here right now, should we be prioritizing a consensus-based weaning protocol?
Let's first come with consensus rest settings on the ventilator.
Yeah, I think there's a role for some consensus around how we wean, particularly VA ECMO. I know that Dr. Kays in All Children's is hoping to publish soon his experience with ECMO with CDH patients, and I only bring that up because they don't clamp. They don't clamp at all. So they come down to what we would consider low flow, leave them there for 24 hours. If they meet some criteria, then that's it. They come off, and so they never truly actually clamp. And I think the way that you introduce safety there, to Maky's point, is they leave the cannulas in for 24 to 48 hours. So that if they're wrong, that the baby is not ready to come off, then you can just hook back up. We practice similar, we clamp, we definitely clamp, but we do leave the cannula in for 24 hours, sometimes 48 hours, sort of as this sort of safety bridge to if we don't have success separating from ECMO. And it's rare that we don't have success. I would say, looking back at the last 7 years, we've only had to use those cannulas about 5% of the time. But I think that's easier than going back into the neck. Sort of that aside, consensus around a lot of these things, especially these high risk, high morbidity things that we do with ECMO, would be very helpful for centers. And it would be helpful for moving the field forward, so that if things aren't working out, it's not center A does it this way, center B does it this way, and there's no way to figure out the path forward.
Yeah, there's a huge variability. Sorry, we can all see that. I am so Patrick, I am impressed. So you leave the cannula for like 24 more hours, clamped. How do you prevent them from falling?
And then what do you do?
Yeah, so we separate. Well, so we do low flow clamp. Usually we'll clamp for an hour or two with, flashing every 10 minutes or so. And then if we decide that we're going to separate from ECMO, we stent the cannula with 2 unit per mil heparinized saline solution. And then we give the baby like 10 or 15 units per kilo per hour of heparin. And so basically it's just like 2 very large IVs. And we run heparinized solution through them, and then a little bit of systemic anticoagulation so that we don't have any clotting of the cannula. We look back retrospectively, we haven't had any clots or other that we can see untoward effects from that practice.
Is anyone doing the retrograde flow practice? Have you guys heard of that too? It's like happening in Europe, and I'm just curious how it's actually working.
We tried it once. It was clunky. It didn't work well. We never tried it again. Yeah, N of 1.
Okay.
We haven't tried it in St. Louis.
Just wanted to see, Jenny, is there any questions that you've seen coming in the QA or anything from chat that we should be acknowledging?
Not really seeing anything. I see just a comment from Golnaz. It's hard to tell. I didn't know if this was just for us or for everybody, but I'll try to summarize some of what she put in here. She's starting her hemodynamics program and just making some comments about how to gain trust with your collaborators, like your surgeons, when you're placing cannula. I think that's really important. I was interested to hear how people, are working with surgeons at the time of cannulation. Sounds like some people have the, trust of the surgeons that, you do your ultrasound, your echo, and find that it's good in position. I think it was Rachael said that maybe they walk away before they even get an X-ray. So that shows a lot of trust. But yeah, I don't know if, I think we touched on briefly how people have sort of gained that collaboration with surgeons, but if anyone wants to expand on that, that might be another talking point. Yeah, that's pretty much it here.
There's something that might be controversial for sure. I've been pushing my surgeons for quite some time now, and I'm finally getting some traction for neonatologist percutaneous VV cannulation. There was a absolutely not, you must be out of your mind type of thing. And then you got these cowboys like Sham doing it in now in Miami. And at Euro also this year, there were multiple conversations about percutaneous ECMO cannulation. So my surgeon texted me from Europe and said, wait a sec, maybe you're not so crazy. Maybe this is a thing. So nothing is final, but we're hoping that by 2027, we're going to do neonatologist percutaneous inserted VV ECMO cannulas. Now, in general, we are a VA center just because of limitations of VV cannulas for so long, but we do need to get out of our own way, get over the mental hump, and be more willing to put a kid who's just on a touch of epi and a touch of nor-epi, put that kid on VV ECMO. Sometimes we get in our own way.
We move on to some of the stuff again that Rachael brought up as it relates to outcome data and that how limited that is as well, especially for echo-guided management. My question is it realistic or is it even ethical to design prospective trials comparing echo-guided versus non-echo-guided management? Is that something that can even be entertained today?
No, I don't think so. That's hard. That's a great question. I know you're being controversial, Mike, and I don't know. As a hemodynamics center and someone who's doing them and looking at them, I'm in Iowa, so we feel this way about a lot of things that other people don't. But I think it's going to be really hard to get real outcome data based on an intervention like this. It's like, what Patrick was bringing up, like we're using like NIRS and we're using all these kind of working into like more advanced monitoring systems, sick bays or T3 or whatever people are using, those kinds of algorithmic approaches. I think it's going to be, it's more data, it's more physiology, but it's how you respond to it, right? And the expertise in the moment that I think is really what's changing the outcome for that individual, that one patient, that N of one, and how to get a research trial to address that N of one patient. Are they better off having had this or not had this? I don't know. I would struggle to see how to do that, but I'm curious from others with more experience than me.
Yeah, I would have a lot of concern about that. If you take ECMO aside and you think about why have we decreased neonatal respiratory ECMO in the field? And that isn't, I don't think, primarily driven by respiratory management, but it's understanding cardiorespiratory interactions and doing a better job of supporting cardiac dysfunction, maintaining ductal patency, and you use echocardiograms to guide a lot of those therapies in the early days so that kids are able to avoid ECMO. So I think that pulling that therapy back from a subset of kids would be hard to ethically be able to do. How you probably move forward is that centers that are using a lot of echocardiogram need to report and need to collaborate and try to show our data, whatever model it is. I fully believe that targeted neonatal echocardiography is the future. We don't have that at my center. We try our best with what we have, but I think that's what I think.
Maky or Amir, anything to add to that? So then looking ahead to other advances, whether it's imaging technology, strain imaging, any other kind of physiological modeling, what do you think might help us better interpret cardiac function during ECMO support? Is there anything else that you think is going to be something that we're going to be talking about in future conferences?
I don't know. I can jump in, but other people please do. I think the thing that is at the tip of all of our minds, like the things that keeps coming up now, is AI and how that's going to integrate into things. And I'm not the expert on that at all, but I think interpretation of imaging modalities, starting with things like X-ray, but eventually I'm sure getting to things like ultrasound and echocardiography is probably coming. And what that's going to look like, I don't know specifically, but I could see a world in which, continuous cardiac output monitoring or, computer assisted, like AI assisted evaluation of ultrasounds probably is in the future, but I'm not sure. Others have.
I feel like the whole point of ECMO is to offload, either pressure offload or volume offload the heart. So your goal should be, can I measure the heart better in an offloaded condition? So I really think echo and the future of echo is cannula position, assessments of SVR, PVR, those sorts of things, and not necessarily heart function in the NICU world. Now, in the study that Rachael presented, where she was looking at TDIs, I believe it was, in cardiogenic shock leading to ECMO, that's a different conversation. And we could talk about cardiac ECMO, but I think for our world, where it's mostly respiratory ECMO, I don't see that being huge. But I do have one question. Let me just throw out there since I have it here. What's the lowest people are willing to go for ECMO in these patients? At our center, the lowest we've gone is 34, and people got really uncomfortable, and there was a lot of, it didn't go well. There was a lot of, questioning whether this is the right thing or not. How low are people on this panel willing to go?
We've gone 33 and change, and we've gone down to 1.6.
That's size 1.6.
Yeah.
How did it go?
It went well, actually. We didn't, as far as I remember the cases, because it's always a discussion. The baby is 33 and 5, right? And then what are the well, we do offer ECMO. We always offer ECMO. And I don't have actually the real numbers, but as far as I remember, there was not increased risk of intraventricular hemorrhage or bleeds,
Yeah,
but
we would
yeah,
do 30.
less than 33, never less than 33. But
we would do 33 weeks and then 1.6 or so. Depends on, if you can get the cannula in, I think we'll try. And a lot of that really is because we have a core team that's used to doing this now, and we have surgeons that trust us that are willing to try on smaller kids. That's made a big difference.
Yeah, we're a smaller volume center. We do our cutoffs are 35 weeks and around 1.8, so we haven't done smaller than that.
Jenny, is there anything else you want to ask? I have one last question before we wrap things up.
No more from me. Thanks.
So this is for everybody. If you could prioritize one area of future research in the echo management of neonatal ECMO patients, what do you think would have the greatest potential to change clinical practice over maybe the next 5 to 10 years? And Amir, I know you kind of touched upon it about where the focus is going to be, but is there something that you would see or you'd like to see moving forward as it relates to future research projects in this domain?
I think that what I would like to see on our campus, and I think this applies to many campuses, is again getting over that mental hump that every baby needs VA ECMO. For respiratory, more VV ECMO. If we can get over that hump, then the possibilities of assessing RV function and LV function become a much more important conversation, whereas in VA, it's not as much. So if I were to answer your question, what would be the most important? Number one, train more people. There's a couple of great hemodynamics programs out there in the country. If there's any young people interested, please join the family. Get over the hump and do more VV. And once we do that, then getting data on RV function and LV function becomes critically important in that sequence.
Yeah, I would hope that we could standardize, how we do our ECMO runs across the country. I mean, there's so much variability on everything, besides echo, like coagulation, like so many things. Who goes on BB, who goes on VA, like at CHOP, the CDHs go always on VA. There is no way we're going to do VV, right? But then we do VV for all the respiratory babies. So, if we could just standardize that practice, I think that per se will just bring better outcomes.
I agree with increasing the role of VV ECMO. I think that with the return of the VV cannula that to the NICU, those runs are, I think they're easier. Weaning is easier. Everything is easier with VV compared to VA, and you're not tying off a carotid. So I think moving forward, how do we get more kids onto VV ECMO? We're very similar in that a CDH would be, unless they would be post-repair or PH crisis or something, they would be very unlikely to go on VV ECMO. And then I agree with how do we generalize some of these skills that you guys are acquiring? How do we generalize them to a lot of centers that don't have this capability would be really wonderful. And maybe it's more of us going and getting trained. But I'm hoping that you guys will just figure out how to make it easier for us.
Come on down anytime. Yeah, I echo the comments from everyone else. I think, for me personally, research arenas I think that are really exciting in this area are looking at like dynamic changes during flow and then during weaning. So I do think that, functional assessments, there is dynamicity even in our respiratory, not our congenital heart babies, but in our respiratory PH kind of population too. And I think PDA management on ECMO is something that we are underappreciating potentially. And I think that is a big area that might be actually actionable and useful in the babies. So those are things I'm excited about looking at more in the future.
I agree. I think the PDA is underappreciated on ECMO. Great point, Rachael.
Well, I want to thank everybody who attended today. A very special thank you to Dr. Patrick Sloan, Dr. Maky Fraga, Dr. Amir, Ashrafi, and of course, Dr. Rachael Hyland. Can't thank you enough. That was an incredible presentation, opened up a very important discussion. It was really enlightening. I loved preparing for this one. It really opened up a world that I don't get to see too often in our NICU. And so there's an area I'd like to see growth is that I think Canada has some room to catch up to what's happening down south of the border in that area. And so I want to thank everybody for their thoughts, their engagement. And Jenny, thank you so much for helping to coordinate this today. Everyone, have a great day, and thank you for attending today's conference.
Thank you, everyone.
Thanks, everyone.
Great job.
Thank you.
5, it'll be a little bit more, and 7 a bit more, or 10 in nanogram per kilo per minute we work. So it depends on the baby. I tend to, if it's already open and you want to maintain it open, we would usually use a lower dose, like 5 or 10 nanogram per kilogram per minute. If it's really closing and you need to open it, you often at least transiently need to use a bigger dose, like 20 nanogram per kilogram per minute, very occasionally 50, which is what we would see in babies with postnatal coarctation. But most of the time, if they're in NICU, usually, and they're being monitored, the duct isn't completely closed. So you can hopefully get away with a lower dose and mitigate those, vasodilator effects. I don't know, Amy, if you have a comment about what you do in Iowa?
I think it's a very similar, and I think the biggest thing is sometimes even on the lowest possible dose, you can really see significant side effects, or you see that PDA just utterly massive. And so sometimes what we've also done is done almost like a pause in the PGE, where if it's feeling like